nutrition in infants. And it says on the booklet that he is Nestlé nutrition. Actually, he does not belong to Nestlé in any way, shape or form. So please do cross this from the booklet, yes?
That's right. So as they said, we're really trying to cover a lot. We're looking at a very big topic and a very potentially controversial topic, about infant feeding practices in developing countries, and we want to see what the broad range of infant feeding practices that we observe, the effects that they have on several measures of infant health, notably length, weight, and disease. Here we go. So this research is motivated by a few key points. First and foremost is that we've seen over and over again in the research that exclusive breastfeeding is essential for infant health. It's essential to prevent stunting, wasting, all of these important health factors that we've discussed so far today. However, we also observe that very few children in developing countries are actually exclusively breastfed. We want every child under the age of 6 months to be breastfed, just because of the health benefits that we see. Mm-hmm. However, in past research, we've observed that only a third of children in the sample were exclusively breastfed. And the others receive a range of foods from coffee, tea, water, infant formula, cereals, fruits, just this really diverse diet in this age group under 6 months that should really only be receiving exclusive breastfeeding. This raises an important question. Specifically, what effect do these different feeding practices have on infant health? Notably, do they have different effects? Does feeding a child coffee or cereal have a more detrimental effect than feeding milks or infant formula? And it's an important question because it really gets at the burden of these suboptimal feeding practices and the potential benefits of switching to exclusive breastfeeding. Importantly, no study has yet examined this question. And so what we do is we try to fill this gap. We want to really quantify the effects of this suboptimal feeding that we observe and is very widespread in many, many countries. I think it's been noted here already that in many of your countries, exclusive breastfeeding is very low. And I'm sure there's a variety of different feeding practices in your countries as well. And so we want to be able to inform policymakers and pediatricians and others influencing the behaviors of mothers about infant feeding. And so what we do is we try to cover a very wide geography. We have a very we're very bold and perhaps too much so. But we look at 20 different countries, and we look at a very large set of microdata that we put together for 20 countries in multiple years. And we look at 6 different measures of food given to children, and we look at the effect on 5 different measures of infant health for 2 age groups. So we'll get into that all more as we go through the talk. But it's a very ambitious project, and we hope that it provides a lot of important information to you, the pediatricians, policymakers, et cetera. So before I get into the details of what we did, I want to summarize what we found. So not surprisingly, consistent with past research, we find that exclusive breastfeeding improves health substantially for infants below the age of 6 months. And what our research is able to do is really quantify those benefits, and we'll see that when we present results in a bit. And also importantly, we find that other types of feeding have different impacts on infant health. Some they're all detrimental relative to exclusive breastfeeding. Some are worse than others. So this underscores the importance of a couple points. One, exclusive breastfeeding is good. We need to keep on pushing that, and we need to improve the prevalence of exclusive breastfeeding. And two, in terms of quantifying the burden of disease, or burden of these inappropriate feeding practices, it's important to differentiate between different types of feeding because they have different effects. So I mentioned our data, and I think that's a big, it was a big undertaking and a big innovation of what we're doing here. We're seeking, as I said, we're very ambitious, and we're seeking to kind of address a very broad geography to attain kind of the most generalizable estimates that we can. So we look at nationally representative microdata from the Demographic Health Survey. And what this survey is a survey of ever married women between the ages of 15 and 49. And it's conducted in developing countries approximately every 5 years, generally funded by the U.S. Agency for International Development with some technical support generally from the U.S. Census Bureau. And it asks a series of questions, has several modules that vary across survey years, but overall they ask questions about the mother's health and about the children's health under the age of 5. And then questions about household characteristics and household resources. Importantly for our research, it also asks questions about the food the child received in the past 24 hours. So we're really able to observe all of the food given to a child in the past 24 hours. Unfortunately, it's not the amount, but simply whether a child received different types of food. And so as I mentioned, we're using 20 countries. This is a list of the countries we use. The survey module on feeding started in the mid to late 1990s. And so we're able to use approximately 3 survey years per country. Some countries there were only 2, some there were 4. But in general, there was about 3. Oh, and I should note, you can see the broad geography. We chose these countries based on the availability of the data. We really wanted to have several years and important food information, but also to get a fairly broad geography. You can see countries on this list from all over. So we want to look at as much infant health as possible. We realize that there are many measures of infant health. And we want to provide a very broad picture of the effect of these feeding practices on infant health. And so we look at the anthropometrics that were mentioned earlier. We look at length for age, z-score, and we look at weight for length, z-score. And then we also look at disease incidents, or I guess these are more symptomatic incidents. Diarrhea, fever, and cough in the past 2 weeks. And these are the 3 symptom measures that are available in the data. So that's why we focus on these 3. We would love to have specific measures of disease, however, we're limited slightly by the data. And we do the analysis separately for 2 age groups, infants less than 6 months and infants between the ages of 6 months and 1 year. Because obviously we think exclusive breastfeeding is important for less than 6 months. That's the recommendation. Whereas for infants between the ages of 6 months and a year, complementary foods are usually recommended. And so these are 2 very different samples that we analyze separately. The most important independent variables in our analysis are the feeding variables. And we use the 24-hour food recall data to construct 6 different measures of feeding, 6 different food types. We look at exclusive breastfeeding, non-exclusive breastfeeding, and then we categorize all other foods into 4 different distinct types. There's infant formula, milk liquids, non-milk liquids, and solid foods. And now, it's important to note that these categories are not mutually exclusive, so that an infant in our sample may have received solid foods, non-exclusive breastfeeding, and milk liquids, for example. And so we experimented with some more complex measures of infant feeding where we looked at specific combinations. There are 32 specific combinations, and so it got a bit unwieldy, the analysis. So we decided to focus on these 6 combinations, or these 6 different feeding types. As was mentioned earlier, I'm an economist, and so I like regression analysis. In this case, it's particularly important to control for confounding factors. There are a lot of factors associated with feeding that are also associated with infant health. 3 specific categories that we focus on in our analysis. First and foremost are community resources. the wealth of a community or the food resources available to a community will influence the types of food given to a child, but also might have an independent impact on the health of that child. So we think that's an especially important point to control for, and so we use community year fixed effects. And this is especially important in this analysis. When you're using 20 countries and 3 survey years per country, things get very messy. And so controlling for, you don't want to allow variation across communities to bias your estimates. And it's a little problematic because it eliminates a lot of variation that could be used to identify effects. However, controlling for confounding factors is important to getting causal estimates, which is what we're interested in. So we lose a little statistical power, and that gives us problems later on. But it's important to get our causal estimates. We also control for household resources and behaviors. Again, these are factors that will influence both infant health and infant feeding practices independently, perhaps. So we're limited in our data. We're not able to use household fixed effects as we are with the community. But we're able to control for many factors that, across the board are seen as important. Maternal employment and occupation, maternal education, maternal weight and height, total number of adults and total number of children in the household, and then whether the household has agricultural land, which we think will be an indicator of potentially having other, cow's milk or goat's milk or other things like that. Finally, and perhaps most importantly, child-specific factors can influence, obviously, the health of the child and what the parents feed a child. We think most important in this category for our causal interpretation is the mother's recall of the child's size at birth. Because in theory, child size at birth is determined by the inputs in utero given through the mother's nutrition, the mother's health care, and also the genetic factors of the child. And these are things that we want to be able to control for. And then we control for gender and whether the child had any vaccinations. So the summary of this slide is simply that we use regression analysis to control for many, many confounding factors so that hopefully we can interpret our results as causal or at least close to causal. Our technique is simply to use ordinary least squares regression with fixed effects weighted by DHS sample weights. And our independent variables, I've already mentioned, are feeding types and then the controls that I outlined on the previous page. We have a slight problem of interpretation in that as I mentioned, the feeding variables are not mutually exclusive. And in practice, we'll observe mothers feeding their children solid foods and infant formula, or solid foods and milk, or solid food, or all 4, and breastfeeding. So we want to be able to compare these different combinations. And what our regression estimates will enable us to do is predict the health effects of different combinations of feeding and compare them. And so we look at 4 different feeding combinations here and compare these 4. However, we could do it for all 32 potential combinations. For simplicity, we'll just keep it at these 4 for now and know that we can get much more complicated if we really want to. Okay, so now into some actual numbers from our data. This first table just gives an idea of the diversity of the feeding that we're observing in this data. Similar to the past study that I mentioned in the motivation section, we observed that only 1/3 of infants in our study under the age of 6 months are exclusively breastfed, much below the 100% that we'd like to see. We see that 63% are non-exclusively breastfed, and then that leaves 4% that receive no breastfeeding at all. We assume that this is in the 5 to 6 month, or we hope that this is in the more 5 to 6 month range and not in the very young ages. For the infants not exclusively breastfed, we see a very big range of the foods given to them. A large concentration receive non-milk liquids, including water, coffee, tea, juice. But some receive solid foods. 27% receive solid foods. And then some receive infant formula and milk liquids as well. So it's a very diverse feeding practice here that we're observing in our data. And this is for a very wide geography and a large time frame. The story of diversity of feeding practices increases, obviously, for the older age group, which is what we would expect. A very small percent are still exclusively breastfed, and there's a much more diverse feeding practices. 92% receive non-milk liquids, 80% receive solids, and smaller percentages receive infant formula and milk. And I'll note the number of observations we're looking at as a key point of our study. And we're looking at a very large data set, about 37,000 infants in the younger age group and 34 in the older age group.
Do you have confidence band for those numbers?
Confidence bounds for these numbers? No, we don't. You mean in terms of standard errors for or standard deviation? I don't have them reported. No, I'm sorry. But yes, I would assume we have looked within countries in our sample, and there is big variation within countries, and that's one of the limitations of our study, is that we are conflating a lot with across-country variation here in order to be more generalizable. Okay, so now into a very relatively complicated table. These are the regression estimates for the younger age group. And so each column represents a different measure of infant health, each one of the 5 measures of infant health that we're examining. The first column is length, second column is weight for length, and then the 3 symptomatic measures that we look at. And so each row represents a different type of food given to the child. And so most importantly here, we see that exclusive breastfeeding has a very positive and statistically significant effect on length and weight, and reduces diarrhea incidence. It reduces fever and cough, but not in a statistically significant way. The main other point to note is solid foods, the consistent negative effect that solid foods have on infant health, at least for this younger age group, below 6 months of age. A strong, statistically significant decrease in weight for length, and then positive increases in diarrhea, fever, and cough. So we're already starting to see some differential effects across these groups of food. Other food, we see one statistically significant negative effect for milk liquids on weight, but very few other statistically significant effects of the other food types. I want to note that just because they don't have a statistically significant negative effect doesn't mean they're not detrimental. They are still detrimental relative to exclusive breastfeeding, and we'll see that in our prediction estimates in a few tables. Table 3, this is for the same analysis for the older age group. The main thing to note here is that there are no statistically significant effects, or at least very few, and none that are consistent across across the measures of health. And this isn't too surprising. This is an age group with that should be receiving some complementary foods, or at least they're recommended to, and they're receiving very different food types. And so it's plausible that there are different beneficial effects, and so it's not so surprising that we don't see any effect on infant health here. So table 4 is the most interesting point here, I think. In this table, we are predicting the effect of different combinations of food. That the first column on the left shows what food combination we're looking at. So that first row is non-exclusive breastfeeding plus solid foods. And then the second column shows the counterfactual feeding type. So that's the feeding type we're switching to. In all cases, we're switching to exclusive breastfeeding because that's what's recommended for this younger age group. And so we see that switching from non-exclusive breastfeeding and solid foods to exclusive breastfeeding has very strong, statistically significant effects on length, weight, diarrhea, fever, cough. Very huge health gains here, because this is only in the 6-month age group, and these gains could potentially project outwards onto higher growth paths. Similar effects for liquid milk or supplementing with liquid milk and formula for this younger age group, although smaller than for solid foods. We see, again, positive effects of switching to exclusive breastfeeding, but not as strong, not as big of a difference as for solid foods. And that's what we found in our regression estimates, simply that these foods are detrimental, but not as detrimental as solid foods, perhaps. So before I move on to conclusions, I want to note some limitations of this research, some of which I've noted already. One is that we're not looking at intensity of feeding. We're simply looking at whether a child received a given food in the past 24 hours. So we're not constructing calorie shares. We're simply saying, did a child receive solid foods in the past 24 hours? And it may be the case that they received only a tiny bit, but that most of their calories come from from breastfeeding. We're not able to distinguish that. And so that's potentially biases our estimates. Similarly, it's only for the past 24 hours that we're looking at. It could very well be the case that the child happened to receive some water or milk or other food in the past 24 hours, but generally doesn't. So we'd like to see more of a long-term food recall, but we don't have that, so we're limited in that sense. Alternatively, you can imagine that a child receives was exclusively breastfed the previous day, but sometimes receives other food. So that bias could actually go either way. But regardless, we'd like to have better data. And some of that is that we're looking at multiple cross-section data. We're not looking at longitudinal data. We'd like to follow a household over time or children over time, and we're not able to do that with this data, and that limits us. Again, that limits us with the number of variables we're able to control for. We're not able to use household effects or child fixed effects, and so we're limited in that sense too. We control for as many as we think all the main ones, things that we think will bias our estimates, but we're limited, and so we point that out. Finally, self-reported recall morbidity data in the DHS has been, may underrepresent morbidity. It's been shown in other studies that if you ask a mother how many times in the past 2 weeks did your child have diarrhea, they might say once when in fact it was twice, and other things like that. So it's a limitation of the data itself. It's the best we have, and we think we hope that it's a decent measure. So, to conclude, I'm pretty much right on time. We have filled gaps in the literature looking at specific different types of feeding on infant health. Previously it was exclusive breastfeeding or non-exclusive breastfeeding. We've filled the gap in terms of evaluating different types of other feeding practices, and this can help us really assess the burden of inappropriate feeding in these countries. And to do that, we've used a very big, fairly innovative data set that we've put together that examines a broad geography and hopefully provides some measure of generalizability. And we've tried our best to be causal estimators, to use causal estimators. We control for as much bias as we think we can get at with our data. So that all helps us fill the gap, this gap in the literature. And so this, just summarizes what Table 4 showed us, just that what we're able to do with this data, with this analysis, in terms of quantifying the burden of inappropriate feeding on infant health. I think these are important takeaway points. Quantifying the burden that inappropriate feeding has is important for policymakers to see so they can address it. Only a third of infants are exclusively breastfed, and that's far below what we think it should be. And providing estimates of the effect of that at the micro level can really motivate policy and decision makers and really help us get the programs of behavior change that we need to pregnant new mothers. All right, I think that concludes. Oh, and this is an appendix that I can show to people if they want, just showing what different measures of food are in each of those feeding categories.
Thank you.
Okay, thank you. I would suggest that we actually make good use of time, so a few questions, because I don't think we're going to get a lot of information beyond what we've heard. On the back there and up front here. The back, somebody?
Thank you for the presentation. Dr. Krishan from Jordan. I'd like to ask whether the sort of solid food introduced make a difference. You have talked about many items under the title solid food. Does it make a difference whether it was a vegetable or a poultry or etc.? The second thing, you were talking and recommending exclusive breastfeeding up till 6 months of age. I think WHO recommend between 4 and 6 months, and here in the Middle East, mothers keep pushing us to start complementary feeding at 4 months. Does it really make a difference, those 2 months? What do you think? Thank you.
Are we taking lots of questions first? Okay. So first, you know, there are many, I can go back to this slide. You know, as you correctly pointed out, there are many things in that solid food category. That's the biggest, most diverse category. You know, we could do additional analysis to look at the specific effects of each one. We haven't yet, but that could be an interesting thing to look at. You know, you know, sifting through that is a little more difficult, but I think that's an interesting point to look moving forward. In terms of the 4 to 6 month distinction, you know, our research was motivated more by the you know, WHO guidelines about 6 months. I have seen other research saying that maybe kind of examining the 4 or 6 month cutoff as potentially not mattering as much, that being more of a gray area. I can't really comment on that here, but I do know that research is out there. We were just focusing on the WHO guidelines.
Can I remind everybody that Ben is an economist? So probably if we can discuss the data he presented. At the same time, we have a lot of expert on micronutrient and breastfeeding. So maybe the floor can also assist in interaction with Ben and the person who's asking.
Thank you very much. I go back to the data written down here and about your methods, and it seems that this study is based essentially on other studies made in different countries, including my own, Egypt, and of necessity the accuracy of your findings will depend on the accuracy of these studies.
Mm-hmm.
And I call into question the accuracy of these studies. if in Ghana, in Egypt, in Zimbabwe, in wherever, studies done by whom? Probably by non-medical persons, measuring measuring length and height and weight, and asking mothers about cough and fever and diarrhea in the last 2 weeks, and questionnaires essentially, and then extracting important, potentially very relevant information from all this. And I find it a little bit stretching the data in this respect. You know, I know how studies are conducted in such countries, and you go by health, public health studies, published data from public health studies, and I really have very big questions about drawing conclusions from these studies in a retrospective manner.
Yeah.
Maybe we'll take several questions and then you can comment. On the back? No?
No? Change your mind.
Andrew? Oh, here.
There's a lady.
There's lady. We haven't heard from the ladies. Okay,
Yes.
2 ladies there.
Please identify yourselves.
My name is Patricia Kaldani. I'm from Lebanon. I'm a pediatrician. What do you think, is there any need to do other growth curves for exclusively breastfed babies? Because by my experience, I think that they should have other, you know, growth curves than the usual standard growth curves that we're using, especially for weight. I know that the exclusively breastfed babies usually have a more lean body weight, and their weight is a little bit less than the bottle-fed babies. So, is this a need to?
We're going to
did you
gather
get that?
questions from this side and
Okay.
then from the other, okay? Yes, go ahead. Big question?
Mariam El-Waili from Oman. Thank you for your nice presentation. Just my questions to you. We know that breast milk is the best, but why you don't take the food frequency questionnaire instead of 24-hour dietary recall? And also we know that the definition of exclusive breastfeeding, that mother should not give breast milk, should not give anything, only breast milk. But sometimes when the health worker they ask, do you breastfeed? They say yes. So they just register as exclusively breastfeed. So did you define that for every mother? What is the mean of the exclusive breastfeed? And also for, we know that breast milk is deficient of vitamin D. So do you ask about the sun exposure or anything like that? Thank you.
Any other question from this side? Yes, one more. No, let's finish here, okay?
I'm Dr. Sahira from Bahrain. I have it's a recommendation rather than a question. Regarding early introduction of solid foods, the practice in my country is to inform mothers at the time of 4 months vaccination not to introduce solid foods. And at that time, most of them introduced it. And that is a wrong practice. What I think is this should be done at the level of antenatal period.
Yes.
Okay, very good.
Which is very important.
Okay, so you have now, can you comment on the
Okay,
comments,
yes.
questions?
So beginning with the first comment on the data that we used, it's not actually from other studies. It's not a meta-analysis that we're doing, I should clarify. We're taking surveys that were conducted and hopefully validated. They're widely used in public health. The demographic health survey is it's a fairly well validated study, or data set, and so I can only kind of rely on them for that. But yeah, I mean, as I mentioned in our limitations, I think that you're very right. Recall data is always problematic. And we do acknowledge all the research showing that it underrepresents past morbidity. So it's a limitation of our study. And any time you're trying to use big data to make big general conclusions, you have to rely on the quality of the data. And generally, the demographic health survey is well validated, but it does have those limitations. I think the next question was about growth curves. And so I probably have to rely on others with more knowledge about that than me. I think that we use the reference median as kind of a standardization as for our dependent variables here. It gives us kind of these standard deviations to work off of. It would potentially bias downward our estimates of weight because for exclusively breastfed babies, as you mentioned, they're not going to gain weight as quickly. And so we wouldn't necessarily expect to see these giant weight gains. And so estimates actually may be biased, maybe downward, may underrepresent the health benefits, which is why we look at 5 different kind of health measures. Let's see, the next question.
But perhaps I can just add, the study added 6 months, so there should not be many different growth charts. The WHO growth chart is the one we refer to always, particularly in definitely under the age of 2 years, possibly up to the age of 5 years. And
Okay, we'll get questions from this side.
Thank you. Mahmoud Zalabani from Egypt. Excuse me for, thank you first for this elegant presentation, but I would like to stress on two facts. The first, that the nature makes this food, which is the breast milk, is the most suitable food for that creature, for this infant. And we do efforts to prove what is proved already, that nature should get back to its origin. This is the first comment. The second comment, why we take 6 months as the cutoff date for exclusively speaking for proper child development? In my experience in my country, I have many babies who are breastfed exclusively for a year or even more, and their general health is very well, and their makeup is very good. Why we take this as a cut off date? Thank you.
Yeah.
Okay, I'm Hagar from Indonesia. Did you calculate the quality of the food intakes from the baby?
I'm sorry,
On
the
your
quality
study,
of the
on
food?
your research, did you calculate the quality of the food intake, at least as assumption, for at least except the breast milk, of course? Thank you very much.
Do you want to answer those?
Sure, yeah, I'll answer those two. First, I agree with you that we're proving nature right again and again, you know. But yeah, it's unfortunate that we need to, it seems. You know, again, we just show that only a third of the children are exclusively breastfed for this younger age group, and it really is a shame because, as you mentioned, nature designed it that way. And in terms of the 6-month cutoff, as I mentioned earlier, well, first of all, it's not so much of a cutoff. We're just looking at 2 different age groups because we think they're slightly different. And as I mentioned earlier, it's mostly because of the WHO standards. But yeah, we do recognize that some children are exclusively breastfed up to 1 year or even more, even to 2 years, I think, sometimes. And so we separate them simply because we think they're different. They may be different. And certainly those are 2 different developmental time periods. In terms of the food quality, we weren't able to really get at that because we weren't able to make a measure of calorie shares just because of the limitations of our data that I mentioned. And so we're not necessarily able to make a good quality measure, which would be essential, or which would be beneficial for certainly the older age group who should be receiving the complementary foods. But that's something we've been looking into a little bit more, and we're trying to figure out a good way of doing that because we think it's interesting.
Do you have a burning comment there?
Yeah, these are very, very complex issues. I've got a great deal I'd like to say, but I'm just going to keep it to one thing.
Do you want to identify yourself, please?
Sorry, Andrew Prentice, UK and the Gambia. So the question I have is about reverse causality, because on your final slide you said you've done causal estimations. But there's an enormous opportunity for reverse causality here. Think of yourself as a mum who's got a baby who's failing to thrive at 3 months. What do? You, of course, assume that you haven't got enough breast milk and you introduce other foods. So I really caution you about your inference that this, unless I've misunderstood it, and please come back to me if I have, but there is an enormous opportunity. So by definition, you get smaller kids whose mums are the ones that will introduce those foods earlier. And the whole issue of the decision about when to introduce other foods is also a very complex issue, and it interrelates with our evolutionary biology, because you said a moment ago that nature has designed it like that, but be cautious about that, because nature has designed breastfeeding as an optimal way to enhance the survival of all that mother's offspring. She cannot afford to allow one particular offspring to deplete her maternal resources so that she can't support the next offspring. So there has to become a time, evolution has made a time, when the mother and baby between them make a decision as to when it is the appropriate time to start introducing other foods. And I think it's very enlightening that we, as public health workers, might say 6 months, but the whole of the rest of the world and we say they're wrong, make a different decision. And I think we need to think about that. So my main question, though, is about this reverse causality.
No, I think that's an interesting point. You know, in limitations, I tried to kind of temper our reverse causality. I probably mistakenly put it again then in the conclusion section. But I think reverse causality is a very big potential problem. What we like to rely on for that is the child size at birth, but that's a very crude measure of the mother's recall of the child size at birth, with the idea being that you know, where a small child will be, you know, potentially be small going forward, and the mother may then decide to, oh, well, I'm not producing enough breast milk. But yes, I mean, we may be more likely to see small children that aren't growing properly then be more likely to receive other foods in an effort to kind of jumpstart their growth a little bit. But I do think that you know, for this, I mean, we're looking at over a 6-month period. So you know, and I know it's a very big, you know, growth is as a percentage of the child's weight and height are growing very quickly. But you know, the child's size at birth is a very big determinant of that, and so controlling for that, I think, potentially gets at a lot of the problem. But some still remains, and causal inference is difficult still. I agree.
Dr. Prentice, we all agree, and the speaker himself agrees, that there are a lot of gaps within the understanding and data collection of this study. And certainly they did not address whether the mother thought that the child is not growing well, therefore she introduced. So this data is not available, it's not being presented. But the issue of whether we need to start complementary food at the age of 4 months or 6 months, whether the world agrees on that or not, you probably are well aware that the WHO has a very firm stand that they suggest 6 months. However, they have not been very dogmatic on that, and a lot of people start practicing it at 4 months. Now, the WHO recommendations, actually, they include the developing and the developed countries. So if you look at countries which are underprivileged and in which there are no other good, adequate sources of nutrition for these people, breastfeeding might be a safe option at that time. But certainly it is an area of a lot of discussions.
On the back there, Linda.
Yes, Linda Dare, UNC Chapel Hill. I fully support the point that Andrew made about reverse causality, and I would disagree that accounting for size at birth takes care of that, because mothers are really observing how their kids are growing and making the decisions. But I also think it's really important to look at age-specific effects. And with longitudinal study that we've done in the Philippines, collecting data every 2 months, it's really quite clear that the effect of not breastfeeding is quite different in a 2-month-old than it is in a 4 or 6-month-old. And so I think it's really critical for these estimates to look at the age-specific effects of not just about the controversy about 4 to 6 months, but the very early introduction is particularly detrimental. And when you look at the entire 6-month period as a chunk, you really miss that very important difference that might have dramatic policy implications.
I think that's a very good point, and I think, you know, our sample is certainly big enough that we could do that, that's a good point going forward. I think I'd be very interested to see that.
May I just return back to the question? What is your experience? What's your practice, both from the UK? Where is your cut-off limit to say that we are going to introduce solid complementary foods? Just feedback from.
Are you asking me?
Yes.
Well, I tell you what, I find myself in a very difficult position, because of course I want to support the WHO policy. But on the other hand, I have the proud claim that I've measured breast milk intake in more women than anyone else in the entire world, and developed new isotope methods for doing this. So I see it from the mother's point of view as well. And breastfeeding is like anything else, like running 100 meters, is a biological construct with a great variation. There are some mothers who simply cannot produce enough milk to support the healthy growth of their kids up to 6 months of age. And it's almost, you know, to try and tell them that they must do so becomes tyrannous. And so, this is a very delicate balance and needs to be understood at many different levels. But the most important thing I'd like to leave you with is in no way am I trying to undermine the WHO recommendation. There are benefits. There are lots of women who are introducing complementary foods too early. If they delayed that, they would enhance their breast milk output. But don't let us allow it to become a complete tyranny.
Let me just come in here, because the rationale for the WHO value, and you know it well because you produce some of the data and ourselves too, in doubly labeled water, and the measurements of doubly labeled water in fact allow you 97.5 confidence band around the doubly labeled water data support up to 6 months of exclusive breastfeeding. But obviously that's for a population base. Individual advice needs to be individualized. That's why there's health professionals. And what WHO is providing is public health advice. It's not providing individual management, which in a way we're seeing here. So I think that we have the best science that we have applied to this, doubly labeled water. And of course, individualized is where the health professional needs to come in and adjust based on the mother and the child.
First, there is on the individual basis. We might ask our Egyptian friend to participate, because he said he had a patients up to 1 year with no.
Yeah.
But maybe Dr. Ramakrishna wants to step in.
Yeah, one comment, not to beat the horse dead further, is having worked with DHS data, there is variation in the reliability of data collection, and the variable that's most notorious is size of birth. So just be double caution. We've looked at it and said we don't want to work with it. So that's something to keep in mind. You need to look at, was this validated from any certificates, and the place where you have more burden of low birth weight, the probability of having it validated is lower. So that's just a methodological concern, that even if you adjust for it, if there's a lot of noise, it doesn't do that adequately. The second point, and I sort of dock my hat at Andrew as one of the few people who've looked at lactation performance, and I think that is, and I'll emphasize it in my presentation tomorrow, while we all agree exclusive breastfeeding is optimal, etc., we have not addressed adequately the role of maternal undernutrition in lactation performance. We have older data that showed, women are capable of breastfeeding and the energy intake may not be compromised, but there is some data to question the micronutrient quality, the ability to exclusively breastfeed, the whole psychological impact. And that's not, again, to undermine the WHO recommendation, but making the case that if we're going to tell women to do this, we need to make them mentally and physically better off to do it, and we've not focused on that issue.
So a lot of support for breastfeeding mothers, yes? Dr. Mahmoud, did you want to add anything?
I think the relation between the mother and the pediatrician is the hallmark of the story, because if I am a pediatrician, behave as a dictator to dictate the mother what she should do, at which time she should have it. But I think the role of the pediatrician is a guidance and a partnership between both. And I think and I believe that no one on the earth will take care of his infant like the mother. So let's back to nature again. Okay, let nature take place. What all we have to do with the mother is to guide her, to give her an information and an explanation, and to consider her circumstances very clear and very honest.
This guidance should be based on science as well.
Yes, for sure.
Yes. Professor Shatut.
Well, Dr. Mahmoud is from Egypt. I'm from Egypt too. And
same part of Egypt or different?
No, he's from Alexandria. I'm from Cairo.
Okay.
Yes, there is like 200 kilometers between us. But we must never remember that many mothers are uneducated, and that this influences their decision making, and that grandmothers are generally uneducated, and they are often very obtrusive and give wrong advice. But I have a question about the exclusivity of breastfeeding, and what about the very common practice of giving infants like dextrose 5% or water in the first few days during which colostrum is being expressed in minute amounts and the infants are crying? Does the WHO recommendation for exclusive breastfeeding also prohibit this practice?
The physiology of this is that the more frequent you place the child in the breast, the easier it becomes.
Yes,
for
of course,
breast
but
milk to flow.
some babies will just go on screaming.
I know
Yeah.
that. I haven't been a mother breastfeeding, but the advice in general is to actually examine the mother's condition in terms of if she's stressed. Obviously, if there's pain, you need to do something for pain, but it's again individualized, and that's where the pediatrician and the obstetrician come in. But that doesn't detract from a general public health advice. I think we have to separate the general public health advice with what do you do with an individual mother in a given case situation.
So generally speaking, there is advice against giving anything from the moment of birth.
Yes, right,
Yes, completely. Professor Jorge, would you like to step in and advise on, on the transition from breastfeeding to complementary feeding, and from your experience, because you had a lot of, and I was very interested because there were mothers who actually donated breast milk for poorer people. Would you like to share with us your experience on that?
I was only thinking that we pediatricians have said the most incredible things in the last 50 or 100 years. I was reading a few time ago a textbook of pediatrics from the 1940s saying that cow's milk was the best because it had a bigger proteins, more as a fat content, and so on and so forth. So my question for this study would be, can you cross-control with the scientific patterns of advice that are being given to the mothers breastfeeding their children? Because in an institutionalized pediatrical environment with primary health care, maternal and child policies, the influence of the house of pediatrics, or the house of medicine, including nurses, including midwives, and including the grandmothers who have a lot of time to intervene, sometimes in the right side, sometimes in the wrong side. So this is one of the social cultural factors that would be controlled, I guess, to say, well, this is what we observed, these are the real times of breastfeeding, but the influences may be different. So that is the question for the author.
Well, I think that in theory, the official advice is that you should be exclusively breastfeeding until 6 months. But I think but we don't know. We don't know. And but I mean that is the WHO recommendation, and we support that, and we come back to that. But within a given country, pediatricians may say something different. Grandmothers, friends, sisters may say something different. But that's we're simply, in this particular study, we're simply measuring the effects of that advice. The impact that advice can have on health, because I think that because the scientific evidence, at least on a population level, says that you should be exclusively breastfeeding, and so that advice, maybe there are specific circumstances where that advice might be okay, but at a population level, we think it's wrong.
Probably one of the problems is that we don't really have good ways of measuring on an individual basis, on a clinical manner, breast milk output. Because that is obviously vital to define whether the child will be appropriately breastfed. But we don't have objective data on an individual on how much breast milk is being produced.
I think it's very encouraging for an economist to support breastfeeding. So we are very happy. I think we are reaching the lunchtime. I would like to thank you, and Ben, for an economical presentation on breast milk, which makes us very happy. I would like to thank all the audience for their interaction and their input. Thank you very much, and it has been a very challenging, encouraging session, and I'm sure everybody is looking forward for lunch and a break. Thank you very much.
Okay, very good.
Now
We come back.
we come back.
Yes,
Are we